Joe Kolars here. I'm the director of the Center for Global Health Equity, and we're about ready to get started with our seminar this evening. I'm just going to do a few mechanics to just make sure I see we have a number of participants that are joining us. I'm just going to be doing a share screen. And let me get that started here and tell you what we have in store for you this evening. Let me see if I can get our slides up. So we've had a cadence in our relatively new center of having a monthly seminar, and this evening's is on Strengthening Systems for Health seminar. This is actually designed as a case study to talk about Rwanda. And for those of you who may be new to our Center for Global Health Equity, I just refer you to our website where we have our past seminars, and you can find out some information about what this center is about. We're designing this for the entire university, all 3 campuses, and it's specifically for collaborating across the campus and bringing us together. What we've been organizing our faculty, we've had several challenge groups that are coming together. These were designed based on a listening tour that John Ianian and I did to try and figure out what are the issues that we were particularly well suited as a university to try and work with our partners and the people that we've been working with in low-income countries. And several themes emerged, and we've got faculty that have collected into areas such as data science for global health, climate vulnerability and global health, or empowering women and communities in low-income countries. So you can, again, go to the website and tune in on the seminars that have been held on those. But we're growing those communities of practice and trying to grow. How are we going to approach funding? How are we going to approach partnering so that we can really have impact? So this evening's seminar is kind of another extension into an area that we've been working, and that's on strengthening systems for health. And again, to bring this point home, we're going to explore a case study on what do we do with a request that's come our way from Rwanda's Ministry of Health. For tonight's discussion, we have a panel of colleagues that I'll be introducing as we go through the seminar. We're going to be kind of talking about how we've been responding to Rwanda's reach out to us. So what is the University of Michigan's response, and how do we navigate that? How do we interpret that? So that's why you're seeing only Michigan people here. We're going to be telling you our side of the equation in response to what Rwanda is looking to us for, and how do we navigate that? So they're very much aware of us talking as a group, but we wanted to share how we're thinking about that, how we react, but how can we come together as a community of practice and response. So you'll be seeing us come together and talk about this. The agenda, I want to start with what I think is the most important part, and that's the discussion. So we've got half of our time set aside for the discussion. But we'd like to set the stage so you have things to discuss, questions, advice that we'd like to hear from you on. And for that, the things that we're going to present to you is, first of all, what do we mean by strengthening systems for health? And how does that differ from health system strengthening? Are they the same or are they different? And what do we mean by that? Next, Sorry here. Next, we're going to be a really hot topic that I think we need to acknowledge and be staring head on at in all of our conversations, avoiding colonialism and global health. There's a big movement afoot in that, and we should be leaders, if not fully cognizant of that. What do we do when we're approached about a collaboration? This happens to me very frequently, and how do we deal with that? Why did Rwanda approach us? Again, we're not talking about a case study where we're going to Rwanda. We're talking about a case study where Rwanda is coming to us. Why? And then how do we navigate a response? So again, that's what our panelists will be talking about. And then we hope to have a bigger discussion on that. So let's start with this first one, strengthening systems for health versus health system strengthening. Most of us are used to, at least over on the health campus, talking about health system strengthening. What is a health system? You know, most of us, if we were true to the realities, end up talking about a healthcare system. Michigan medicine spends most of their time on health care. It's not health, it's health care. You look at WHO, they've looked at 6 core health system functions. Service delivery, we do a lot of that. The human resources for health, medical products, vaccines, and technologies, information, governance, finance. So that's a health system. So a lot of people do health systems for health and strengthening health systems. Yeah, we've done that. Our medical school, our nursing school, our school of public health. If there's a space I think we've been particularly active in, it's the human resources for health, what people sometimes will refer to the acronym of HRH. So that's health system strengthening. To try and make the distinction with strengthening systems for health, I'd like to quote somebody I've been a big fan of. I've had a chance to spend time with Desmond Tutu. One of my favorite quotes that I'm pretty sure is attributed to him is this: there comes a point where we need to stop just pulling people out of the water. We need to go upstream and find out why they're falling in. So where do we spend most of our time with healthcare system strengthening? It's pulling people out of the water. I think we spend relatively little time thinking about the upstream factors, population health, the social determinants of health. Of course, our people in our School of Public Health, in our School of Education, in many of our schools, they're thinking about the social determinants of health. That should be keeping people from falling in the river. And for us, that's what we think about when we're thinking about strengthening systems for health. What are all of those systems that are going to contribute to a person's health, not just strengthening health systems? So it's a subtle but very important distinction for us. We want to strengthen systems that will contribute to people's health, not just focus on health system strengthening. So a second point is avoiding colonialism in health. And this is a big movement. Presumably you've read one of these books. I've read, I think, all of them. But the whole point is that there's a real focus on the global health movement about people in high-income countries, in privileged states, going to local income settings and saying, we've got a fix for you. We've got the cure. As you can imagine, nothing would be worse than people like us importing all the problems of our healthcare system in the United States to low-income settings. But there's this whole colonial mindset that's hard to break out of. It's hard for me to even break out of when we're thinking about trying to partner around equity and to try and be a good listener and trying to be attuned. And some might say, well, it sounds like you're not going to have that kind of problem, Joe, if Rwanda is coming to you. But at least many of us find that in low-income countries, there's a lot of times people are trying to reach out because they're trying to replicate our system. There's been a lot of money spent in Rwanda, and a lot of it is in many ways trying to duplicate things that we have that probably aren't going to be in their best interests. So I think we have some pretty big challenges ahead of us in terms of how we are going to decolonize the whole global health movement. Things as simple as, those of us in the global north all talk about global health. You go to South America, you go to Africa, you go to low-income countries, they don't talk about global health. So there's this whole language, there's this whole dynamic that we have to figure out how to navigate. But it's something we're very attuned to in the Center for Global Health Equity. And especially when we're talking about that word equity, we have to figure out how to do better with this space. So the next set of bullets, what do we do when we're approached about a collaboration, and why did Rwanda approach us? So I'm Dean of Education and in charge of global over in the medical school. So it's probably once or twice a month somebody is reaching out to us trying to say, we want to partner, we want to collaborate, we need this from you. And how do we respond? It's been a long time, years since I've gone someplace kind of on my own and saying, I'd like to explore this place. It's, for the past 10 years, I'd say I've largely just been in response to somebody who wants me or us to be in a place. So how do we choose? How do we figure out the things that we're going to do and the things that we're not going to do? Of course, we want to be responsive to those who are asking for our help, but it's not that simple. How do we choose? And let's take the example of Rwanda. And again, now we're going to kind of focus with some of these principles in mind to try and keep focused on why did Rwanda end up choosing us. So I'm going to answer that question with just a little bit of background. And I want to start with this slide because it shows several things. First of all, it shows this, this woman here in the left. Hopefully you can see my pointer, Sanait Faseha. Some years ago, Sanait and I started to partner when she was a faculty member at University of Michigan on developing our Ethiopia platform. I was at Gates. I had worked with the person, Tedros, who is now the director of WHO. Sanait was from Ethiopia. We started developing an Ethiopia platform that was just terrific. Sanait went on. She ended up leaving to direct the Susan Buffett Foundation. She founded this Center for International Reproductive Health Training that's been just a gangbuster center at the University of Michigan that is focused first on Ethiopia. Then it's expanded into Rwanda, and it's involved a number of countries. We've had a number of our faculty go there. Janet Hall has been instrumental. The leadership has recently turned over to Yolanda Smith, Tomrat. It's brought in people like Ella August, our pre-publication support service. So there's a huge movement. So for those of you who don't know CERT, be aware of this website and know that that's a very active dynamic. So why am I bringing this up, and how does this pertain to why Rwanda? The president of Rwanda had been visiting Ethiopia a couple times, and he said, "Wow, we really like what University of Michigan has done in Ethiopia. Would University of Michigan come and work with us in Rwanda?" So again, Our health programs had been active, School of Public Health, the medical school, engineering, others in Ethiopia. And he seemed to see more action and more return on a relatively small investment than what he was seeing from some of the other activities, which you'll hear about in Rwanda. So he said, wow, would you come and be active in Rwanda? So this was the president, based on what he saw of the University of Michigan activity in Ethiopia. So he started to talk through his Ministry of Health, and they reached out and said, you know, we've got money to support a partnership. Would you come here and partner with us? So again, we often get these overtures. One of their starting places was, we've got this 10-year plan, National Strategy for Health Professions Development. It's about this 190-page, strategic plan. And basically, it's a huge scale up for how they need human resources for health. And for those of you who are in this space, a lot of countries have this. They want more of everything, and they have graphs like this, where they have the years out here and they have the healthcare workforce. This happens to be their Master of Nursing and Critical Care Trauma, and they have their targets and they have their plan. And won't University of Michigan come and teach and help grow our workforce? So this is a very, very common request. So this is why Rwanda wants to work with us to try and grow their workforce. So this was the starting point for conversation. Again, a very common request and overture for us at the University of Michigan. Another starting point, another overture we were getting from Rwanda is from their newest university. This is also a common request from us. Rwanda's newest university is called the University for Global Health Equity, a very familiar name for those of us who are sitting in the Center for Global Health Equity. And basically, and they're a very well-supported new university who, again, are focused on global health equity. And they said, wow, University of Michigan, we like how you collaborate. Will you come and teach? Will you do student exchanges? And again, this is a very, very common request. So these were the two overtures. Why did they reach out? They knew of some of my work. The dean was a friend of mine for some previous projects. As you'll hear from Jody, Lori, and some of our other panelists, many of us have been active in the region in terms of the human resources for health. So they turn to us and they reach out. So a lot of times when people are reaching out to us, it's on the basis of a personal relationship and some trust. So that's how people reached out. So we've marched through most of these bullets as far as setting the stage for Rwanda in our case study. Now we're going to move to navigating a response. So what do we do if we have these kind of structures for our thinking, these kind of values? They're excited. They want us to collaborate. They like the way we collaborate. What do we do? So when I'm thinking about a response, one of the things, of course, I'm trying to understand what are they looking for and where is there a win-win? We'd like to be of service and helpful to everyone, but if there isn't something that's of value to us, it's not going to be sustainable. So we have to figure out what's the win-win. So my first job is usually to try and say, how can we understand the context? So what you're going to hear next are some thoughts about the context, and I try and look around and say who around the university has some views on this situation. So we're really fortunate to have with us in the Center for Global Health Equity, Christabel Sifa, who comes to us actually after a career at the World Bank. So she's been in this space. So she's going to tell you a little bit about her journey, but a little bit about this space and kind of her view on Rwanda. And then we're going to hear from some people who have had some direct experience there. So let me stop my screen sharing and introduce to you Christabel Sifa, who will share with you her perspective. Christabel?
Thank you, Joe. Let me just begin screen sharing here. Good afternoon, everyone. It's a pleasure to be here and to be able to speak with you on this very exciting topic. Sorry, I just need to navigate my screen here. There we go. My name is Christabel Sifa. I am a project manager for the Center for Global Health Equity. I'm a newbie to the U of M family. I joined the center in November of last year. Previously, I had worked, as Joe mentioned, at the World Bank, working in social protection, jobs, and health programs in sub-Saharan Africa. My work really mostly focused in on Ghana, Liberia, Sierra Leone, and Comoros. My previous experience involved really supporting government systems to implement social protection programs to improve human capital among poor families. We worked with governments to design financing, technical and fiduciary support systems, mainly to support the development of social protection and health programs on the continent. Project design around social protection, building linkages to human capital initiatives, particularly around universal healthcare coverage, and monitoring and evaluation for impact were some of the key activities that we undertook. So that's a bit about my background. I was born and raised in Ghana, and now I live here in Michigan. It's a really exciting place to be at this moment. Just to give a bit of a background, the World Bank's system for defining health system strengthening from their health, nutrition, and population strategy talks about putting together the right chain of events to ensure equitable access to effective H&P interventions in a continuum of care for people. This is a mouthful. They go on to define a few buckets under which support will be provided to countries around health system strengthening. Some of this overlaps with some of the pillars that Joe mentioned in his presentation earlier from the WHO, but there are some expanded additions as well. Key amongst these that the World Bank really focuses on in terms of their comparative advantage are particularly around financing and improving universal healthcare access, governance and insurance. There are other things, there are other aspects that the bank collaborates more with other organizations such as the WHO to implement. And this would be work around providers and setting up systems for managing certain disease conditions. They are less well versed, the bank focuses more on the systems around health system strengthening. So just taking in a sort of a deeper dive to look at Rwanda as we were approached with the possibility of undertaking this collaboration. The context is a very interesting one that has been really attractive to us. There are some key features that make Rwanda a very interesting place. The first is it has experienced some really good, strong economic growth. It's been about 5 percentage points growth per year over the last 20 years, which is the second highest on the continent. So it's really a place that has some really strong fundamental macroeconomic strengths going for it. Secondly, there's impressive health sector leadership and results. The Ministry of Health is very strong. It has, as Joe showed you, a very well-detailed and laid out plan for improving capacity in the healthcare sector. It's one of only 2 countries in sub-Saharan Africa that achieved all of their MDGs on health. And so there's some really good leadership there, not only at the Ministry of Health level, it goes all the way up to the presidency and all the way down to the implementation partners as well. Rwanda also has a very good decentralized healthcare system with about 60,000 community workers and about 500 health centers that really penetrate and ensure that there's access at the lowest levels to healthcare. And then finally, there's this demand side innovation around improving access to health insurance through a community-based health insurance scheme which has really enabled families and households in the population to be able to access care at an affordable price. Now, this context has made it really attractive for other partners to be involved in this space. In terms of the health system strengthening landscape, there are several partners that are already involved. The World Bank, for instance, has a $75 million operation to strengthen the system, facilitate a more equitable distribution of specialists, and to increase the number of public sector workers that are hired through the government system. The $152 million 7-year PEPFAR and Global Fund funded human resources for health projects has been a key support to the country over the last decade. It has supported important skills upgrades for nurses and specialists and ultimately increased the number of healthcare workers. It involved about 13 US institutions with faculty traveling every year to provide support for training and for system strengthening. The results of this project are referenced in an evaluation that was undertaken by the National Academy for Sciences last year. Key results include just increasing the number of doctors available to the population. It increased the ratio from 1 in 16,000 to 1 doctor per 8,900. And essentially reduced also showed improvements in access to midwifery, dramatically improving midwives per population from 1 in 66,000 to about 1 in 4,000. So it did have a significant impact in terms of both the numbers and the quality and training of staff available. As an offshoot of this, several universities continue to provide support. So Harvard University, Brown, VCU continue to provide training and health system strengthening support. USAID is also very active with an $80 million per annum investment in Rwanda, as well as Partners for Health, which is connected to the University for Global Health Equity. We decided to look at these partnerships and pull some lessons and examples for how we should begin to think about our potential partnership with Rwanda. First is really continuing to engage high-level government champions to maintain the vision and mitigate any macroeconomic and fiscal risks. We have been lucky and really blessed to have a team that is really interested in championing this work, and it's important to continue to maintain that high-level engagement. Given the sheer number of collaborators that are already working in Rwanda, it's important to continue to build collaboration. So we want to make sure we're not duplicating, that we are not, that we are making sure that we are synergistically implementing what we are implementing on the ground with the partners that are already on the ground, and building on existing systems, as well as including a broad spectrum at the table. So Ministry of Education, UGHE, others who would be involved in this collaboration being involved at the table. There are some prerequisites, policy reforms that are important to keep an eye on. Some of the lessons from the HRH project showed that it was important to ensure that there was issues around retention and salary structures of faculty were resolved to enable full participation. So that's something that we are going to continue to keep an eye on. Obviously, in the midst of COVID, it's important that we think through technology and plan to address any infrastructural constraints, internet access, computer space for any training or collaboration that we would undertake with our counterparts. Respect is important to us. We think it's very important to develop a collaboration, a partnership that is a win-win based on mutual respect, trust, equity, and thoughtful communication. We are aware that there are cultural differences between us and Rwanda. And so that needs to be taken into account as we begin to think through the different aspects of the collaboration going forward. We want to continue to ensure contextualization in the training. We want to understand what the actual current gaps are on the ground and tailor our interventions not to idealistic goals, but really to the realities on the ground. We want to be sensitive to consider the time constraints of our partners and making sure that we rebalance existing workload to ensure that faculty can fully participate in the collaboration. It's important to realize that faculty and staff in many cases are already overburdened. And so any additional responsibilities through this collaboration will have to be rebalanced with the existing workload to make sure that we are fair and that we can actually get their maximum time for participation. I think keeping the flexible timeline is important in recognizing that change takes time. Adapting systems to take on new functions takes time. And so we need to recognize that if we really want to be involved in this space for sustainability, we need to be flexible in terms of the time commitment and really put in the work and the time that it takes to get the results that would be sustainable in the long run for Rwanda and would be the kind of partnership that they are looking for based on the experiences that they have seen in Rwanda, in Ethiopia. And then finally, I think having a strong monitoring and evaluation framework would undergird every aspect of this collaboration. It's important to maintain an agile approach to implementation. So being able to monitor as we are going along, what results are we achieving, where are we falling short, and how do we need to adapt or adjust our implementation modalities to meet those constraints would be key. So having a strong routine monitoring and results framework to support this project would be crucial going forward. And with that, I'm handing it back over to, thank you.
Great, well done, Christabel. Thank you. And I know why you're stopping your screen slide, your share. Please know that we're building towards a discussion. Feel free to start populating with questions, and know that we're not leading up to just a focus on training health professionals. We're thinking much wider than that. So keep the faith that we're connecting to that. But next, again, as we're trying to understand the Rwandan context and whether we want to go into this space, we're going to turn to a couple of people who have spent time in that space. We were lucky to recruit John and Kirstin Scott a couple of years ago after their time in Rwanda. John is a trauma surgeon. Kirstin is an intern in emergency medicine. They're going to tell us what they were doing in Rwanda, what they saw, and how we, and they're going to be part of the discussion on how we might shape a collaborative platform and the kinds of things that would be win-win. So, John, I think we're going to start off with you.
Excellent. I'm going to pull up our slides here, and I'll just start by saying how excited I am to be a part of this. And let's get are my slides showing?
Yes.
My slides, great. I am in my second year here as a trauma surgeon, and I'm going to let Kirstin introduce herself here in just a moment. I would love to talk to you all day about Rwanda's trauma system, but rather than that, I wanted to just go through a vignette and give you a little sense of the incredible, incredible time that I had, and Kirstin's going to give you her own lens. We were really fortunate to spend a few years living in Kigali. And for me, it started here when I was a global surgery research fellow. I did my general surgery training at the Brigham Women's Hospital in Boston. And during what we call here at Michigan academic development time, I did a global surgery research fellowship in Kigali or in Rwanda. And that's what took us to live in Kigali there. It was an incredible, incredible time. And this photo here is me as a resident surrounded by a bunch of other residents. And the gentleman to my left, screen right, is Dr. George Takiruta. And I was really there as his invitation. He wanted to develop a training program to teach what we call in surgery non-technical skills. So surgeons love to be technically excellent, but we also have to be great communicators and great decision makers and great team workers. And he had seen in Scotland a curriculum for it and said, you know, this is really great. I'd love to do it, but I don't think it would really work here in Rwanda very well because it was all sort of fit for the Scottish context. And I would love to develop one here. Turns out the guy that developed that initial Scottish curriculum was working at the Brigham. One thing led to another, and I found myself going to Kigali to learn the context. So one of my first days as a surgery resident, I want to go to the operating rooms and see what things are like. And having been to Africa before, this was not a uncommon scene. This is a small procedure being done under local without general anesthesia. And that seemed like a pretty normal thing to see, except in the room right next to, or right in the same room, there was a lot of work to be done, but not necessarily a lot of space to do it. And, this is one OR being repurposed into 2 operating rooms. And then the next day, I went to a different hospital a few miles down the road where I wasn't part of the cardiac surgery team, but where they do cardiac surgery in Rwanda. And so really off the bat, I saw the differences in the capacity of the 2 hospitals, and in realizing that residents go from one to the other, just the skills you have to excel in both these environments are a variety of complex skills that we don't normally talk about. So for my research part, this is sort of a boring research slide, but I did the stuff in blue. We did a lit search. I interviewed every surgeon in Rwanda because at the time there were less than 30. Fortunately, because of HRH, that has changed a lot. And one of the big take homes as we built our curriculum was you can't just build, it's not a low resource setting in Rwanda, it's a variable resource setting. And that to say that there's fixed scarcity is just not accurate, because one day you are doing fiber optic nasal intubations and the next day there's no linens, but it's not that there's like a fixed scarcity. So what we did with that was add to the literature this concept of, instead of it becoming the curriculum for a low or middle income country, it became the curriculum for a variable resource context. And so we talked about resource variability, staff variability, communication variability, and systems variability. And though this was an academic work product for a specific curriculum, this really exemplified, was borne out in all of my relationships. And what amazed me is that to my Rwandan colleagues, this wasn't a phenomenon. This was just Tuesday. This was just doing normal work. Well, what was exciting, we built some videos, we put together a curriculum, and then my research fellowship was over. But because of the strength of the partnership, NOTS in Rwanda is not over. So since I left, I got out of their way. They've now had they've had national conferences teaching the course. Then they had a training the trainers conference so that they can teach others. And now it's being taught at the district hospitals and incorporated in the regular skills curriculum. So this was not what the Americans said, hey, here's what you ought to do. Let me show you how to do this. They said, hey, we want to build this thing. We want to use state of the science, state of the art education tools. Can you help us? Because you know some folks that can help us build it. And then when we left, it just kept going and going and going. I think this is just a beautiful vignette of real partnership that lasted long after I've been gone for, unfortunately, many years, and this keeps going and keeps going and keeps going. And it's really a success story, and it's the leadership of our Rwandan partners, many who are seen on the screen. And this is just how they're doing it. This was the most recent quote. Somebody sent me this video. They're training folks who are going to go work at district hospitals in the sim labs on how to tie knots, like how to do surgical technique, while also teaching them the non-technical skills. So they said, we're learning knots while we're learning knots. And that's what they're up to right now. So, there's another great story to be told that I'm not going to tell right now, but the other half of my time there was spent with Rwanda's pre-hospital system and the ambulance system. And so I talked about an education component. There's a data component here. There's just an inspiring group of folks that were already using real-time data to drive continuous quality improvement. But again, that resource variability kept coming up over and over and over. So what did I learn? I learned that Rwanda is indeed a variable resource context. It's not a high resource African context. It's not a LMIC. It's a place where from day to day, you're going to see big swings in what's happening. There's a lot of folks who are eager to leverage collaboration and grow with their own vision for things. It wasn't my vision for it. I was there to be a partner. I was there to provide some expertise and to learn myself. I saw a lot of collaborations that were short-lived. They were as long as the American partner had funding, and as soon as that funding went away, the partnership fell apart because they didn't invest in developing sort of who was next, but also often it was the vision of the visitor as opposed to the vision of our Rwandan colleagues. And that's why I think NOTS was so successful, because that was their idea. And I really think going forward, the big pitch is a systematic approach in real partnership is going to be how we can make sure that we have sustainable growth. And that's why I'm really excited to get with MGlobe and the folks here at Michigan. They're really state of the art across the globe, and see what's next. Lastly, I'll say, if you want to build partnerships, you can start an American flag football team. And this is the Kigali Tigers here. At the time, my dad coached football at Clemson. And so we got some Clemson practice jerseys sent over, and we started the first ever American flag football team there. And the Kigali Tigers are still going strong today. So that's another, maybe that was my vision I brought to them, but it's still going strong.
Great. Thank you, John. And good. Another perspective from Team Scott.
Oh.
Great. Good evening, everyone. It's such an honor to be part of this discussion and just approaching this with such humility, because it is just our perspective from this incredible experience we had to be welcomed to Rwanda. So as Dean Kolars has shared, my name is Kirstin Scott. I'm one of the emergency medicine residents and interns here at University of Michigan. But I had a pretty long journey before medical school, doing health policy doctoral work. And that was kind of the context that led me to join John during his research time in Rwanda. So one of the questions I was asked to cover is, what was I doing in Rwanda? And it's a very difficult question to answer, but I think in the simplest terms, I was literally finishing up my PhD in health policy at Harvard, but my dissertation committee was very gracious to trust me that I would be able to complete this work while living abroad. And the reason I felt so compelled that I did need to make this move is that, as sort of has been the theme of this whole evening, I had this incredible, felt like once in a lifetime opportunity as I was invited by the, at the time, Minister of Health, Dr. Agnes Binagwaho, to join her. So I call it my year of getting my PhD and then AB degree for Agnes Binagwaho. So fundamentally, and really my comments tonight is just sort of big picture life lessons I learned through this remarkable opportunity that I hope we can share more concrete stories and lessons in our discussion time. But it really falls, I boil down to the term accompaniment, that learning from such a powerful, charismatic leader who was just such a visionary and also implementer of innovations and change in Rwanda for the health system was truly remarkable. So if I had to say what a typical day was, there was no such thing. I spent time, many days, I did scholarly work in terms of supporting the minister's writing projects. She was so eager to share the story of Rwanda and innovation. So we were constantly working on articles, op-eds, corresponding with leaders in healthcare, global health, joining her for her quote unquote Minister Mondays, where she was connecting directly with her, the community, and anyone who wanted to ask her questions about the healthcare system in Rwanda was free to engage with her. And then we would have, she had these incredible speaking engagements around the world that I had the privilege of joining her for, preparing her remarks for various speaking engagements. She was the NIH Barnes lecturer, such an incredible honor. So spending time with Dr. Fauci, who now is a household name, and of course, Dr. Collins, director of NIH. It's just, the days were remarkable there. And I just felt so privileged to be learning the principles of equity from really one of the world's leaders and innovators in this space. So some very brief lessons. that I learned from her in my AB degree. Leading by example for growth. I took this picture, it was within my first few weeks of joining her in Rwanda, and she was defending her PhD, our dissertation. And of course she passed because she is incredible. But this was a lesson to me because she was so keen on having her staff at all levels in the ministry to be advancing their degrees, that they should be enrolled in an MPH program and move on to a PhD program, because the vision of Rwanda is to have Rwandan leaders and the next generation be the experts of healthcare in Rwanda. I also love this slide because this is one that she will use all the time in her talks, is that we do not call what's happened in Rwanda a miracle. Christabel had shared some incredible statistics about how Rwanda has just been truly remarkable in their health achievements on multiple scales and levels. But this is not some miraculous story. It's been intentional hard work. And this discussion of the minister with Dr. Glass, who leads Thogarty at NIH during one of his many visits to Rwanda, is just a testament of these discussions at the highest levels, but then the hard work at the front lines that the health ministry staff was helping to direct. Then this photo is a discussion or a picture to show how this whole story of UGHE that Dean Kolars had mentioned was, just this incredible story and journey of people who've known each other for years and who were dreaming big. So the process of creating the University of Global Health Equity formed out of years of discussions and partnership and opportunities for growth. And this is the community that really helped to get this incredible university started, that we're so thrilled that the University of Michigan is working in partnership with. And then one of the final lessons here is just remembering that there's still a long way to go. And Rwanda has made such great strides, but they're so eager for continual change in the vision that they have elucidated and articulated and are bringing partners along for. And with that is that as they move towards these goals of the growth they would like to make, I think my most important reflection is that the power of friendship has really been critical to their advancements thus far. And I really believe that's the case for the remaining journey ahead for the innovations that they are so eager to be making. And our personal experience of just the friendships that we formed that are continued to this day and are so rich in our lives. I just feel that at the most meta level for Rwanda and global health, that it really comes down to sincere friendship and relationship to move these beautiful positive changes forward. So at the end, if you ever visit Rwanda, you will hear this term, amakuru. You would respond Nimeza, and then I say Nimeza in return, and it's to say, how's the news? And the news is good, and we look forward to being part of the conversations to keep the news being good. So that is all that we have to share, and we look forward to more discussion.
Great. Thank you, Kirstin. So again, where we are in this case study is I'm trying to understand, what does Rwanda want and where do we fit? Boy, it sounds like a good place. Boy, it sounds like they've had a lot of money and things going into it. And then you hear about Kirstin's story. She's working with Agnes. Agnes was by far the most transformative health minister in Africa. Before that, probably the best health minister was Tedros, who left Ethiopia to run the World Health Organization. But Agnes, wow, incredible health minister for Africa. So that's who Kirstin was spending time with. So we've got connections, we've got things to do, but then you can't help but wonder, what's Michigan's niche? There's been a lot of people in Rwanda. What are they reaching out to Michigan for? What's our added value? Should we really be going into a place where other people have been doing so much, or we should be going into a place that maybe there haven't been partners? But they've got money, and we can't do things for free. So let's keep the conversations going. Through a lot of conversation, we started to funnel down on 2 areas where we could maybe bring value. One of those areas was in maternal care, particularly around nursing. So they said, well, maybe an area we could focus on, instead of everything, could we start with maternal health? So that looked like a win-win to me, because what we, when I look over at my colleague, Jody, who oversees global health in the nursing school, a midwife who's done a lot of Africa, she's had a real perspective on that space. And I'm going to turn things over to Jody to talk about what is that space, where could there be something for us that we could develop a collaboration and a partnership with Rwanda. So Jody?
Thanks, Joe. And I'll share my screen. Okay. How's that?
Good.
Thank you. So good evening, everybody. I'm Jody Laurie, as Joe said, from the School of Nursing. And as he mentioned, the Ministry of Health and the University of Rwanda, along with the University of Global Health Equity, which we've all been talking about, approached us to talk about a partnership with nursing and midwifery. And I think that it's really interesting and it's really important that they identify this as a place that they wanted to focus. When you think about high impact investments, which funders are always looking for and ministries are always looking for in research or development, when you look at the kinds of data like you see on the screen now, you can see how strengthening midwifery and nursing could really make an impact. The global nursing workforce is nearly 28 million. So we're a big part of the workforce, and we are about 60% of the workforce that's out there. So if you can make a change in nursing and midwifery, you can really affect the outcomes for women and babies, but also all across the spectrum for nursing. I just want to say briefly about the Lancet Commission. I'm not going to read this, but Joe was talking about the importance of strong health systems. We want to really think about how to have quality. Some places now, and Christabel shared, the numbers are really up. They really have a lot of providers, and now they really want to make the shift to how can we be providing really high quality care in our systems. And part of the Lancet Commission is also advocating for the use of data to make these kinds of decisions. So how can nurses, how can midwives, how can we use the data that's out there to actually make decisions and to be providing evidence-based care at all levels of care, from the community to the facility to the tertiary care hospital? The other thing about quality is that the National Academy of Science, Engineering, and Medicine also came out with this Crossing the Global Quality Chasm in 2018, and you can read the statistics on here. But I think what excites me about working with Rwanda is the opportunity to help them build their vision for nursing and midwifery into something that can have a long-term and sustainable impact. One of the things that I think is really helpful for nursing and midwifery is that we have a lot of documents at a global level to help shape the way that we strengthen nursing and midwifery, because we have a very strong International Confederation of Midwives out of The Hague. We also have a strong International Council for Nursing that have developed a lot of documents to help guide us in this work, and that we can just use and make relative to the context, but with with some direction from them, and also from the WHO. There's a lot of work that's been done at the WHO related to quality. And then just the other thing that I want to talk about impact, to kind of just wrap this up, is that there have been a couple of things in the Lancet Global Health related to midwifery. And you can see down at the bottom that it says universal coverage of midwife-led interventions could avert 67% of maternal deaths, 64% of neonatal deaths, and 65% of stillbirths in the 88 countries with the highest portion of maternal deaths. And I think one of the things that the pandemic has brought home to us is that how important it is for all of us to work together on problems, on huge problems that the world faces. And we can learn from each other on these things. I think it really is, as Joe was saying, a win-win situation, because we can really learn things of how they deliver care in very rural and remote areas through their public health systems, which we have been struggling with in this pandemic. And so I think, our students can learn, our faculty can learn, we can collaborate together, and I think we really can form something that can really make a huge difference, both at the University of Michigan and in Rwanda. Thanks, Joe.
Great. Well, thank you, Jody. I just have a couple of slides left to show you where we've been, so what have we done with all this? We've had so many conversations with the Ministry of Health that have been really productive to try and find some common ground where we can get traction. One of them, Jody was just speaking about, is trying to shape an initiative around leadership in nursing to transform midwifery and some of the other aspects of nursing along the train-the-trainer model, so that we can really be helpful there, again, in a co-design model. But I've been involved with so many Zoom calls with Patrick Nduzumbi, who's in the Ministry of Health. He's the #2 person in the Ministry of Health who's in charge of that 190-page report. And we've been figuring out how to find a point of traction and to co-design a win-win model that satisfies their needs. And I had to tell them, we can't just come there and train doctors. There's not anything in that for us. It's not a win-win. We can start off, it's not going to be sustainable. You can get a grant, you can pay us a little bit. When the money's gone, we're gone. And that's the story of Africa. But if you try and get a body of work that makes things really sticky, that would be really interesting. So we had a series of discussions around the whole concept of what happens when people get injured, trauma in Rwanda. And you can see people like John Scott up here. Abebe Pekela is the dean of the University of Global Health Equity, Christabel, and we've been shaping this initiative that looks something like this. It's an evolving draft. They're tremendously excited about it. But instead of just training maybe doctors to do trauma surgery, maybe the equivalent of pulling people out of the river, but what happens to people when they get injured before they ever get to the hospital? And can't we keep people from getting injured? And then after they're injured, after they're in the hospital or in the operating room, what happens to them? So taking a complete systems approach, thinking about education and all the other components that relate to trauma and quality and prevention, and actually training people for a different kind of healthcare system. I didn't know if they would go for it, but they're so tremendously excited about it. And this is the kind of thing they want to invest and want to build in. So now we've got this design team, which I'm very excited about. It's the Rwandan Ministry of Health egged on by the president. It's the Rwandan universities, both the University of Rwanda and the University of Global Health Equity. It's our University of Michigan, John Scott, Raghavendran, Krishnine Raghavendran, who heads our trauma surgery. We're famous for trauma surgery and what we've done around quality in public health and population health around trauma. And it's a great design team that's moving forward. So I think it's a great case study of how we want to take somebody who's interested in us and try and engage in a lot of conversation to find the win-win. In my last slide before, I would love to see more questions and conversations, but this is our hope. You've heard a lot about kind of relationships and friendships and who knows who, but can we extend trusted partnerships into a platform where people in Rwanda and Michigan who would be interested in collaborating for impact can find each other? And that's what we're in the process of shaping. This isn't the only thing that the Center for Global Health would be doing, but it's an example, it's a case study. So how does this play out? You heard us talking about challenge groups earlier. You know, one of our challenge groups is around climate vulnerability and global health. Now that we've got this relationship with the Minister of Health and the universities, who are very appreciative and think that we're a completely different partner than what they've had before, it's not that hard of a segue to say, what are your issues you're wrestling with the climate environment? Who's wrestling with that? What ministry are they in? Who's in the university? Can we start to get some of those people together with the people who think about this at our university? Can we kind of walk down the road that led to a concept paper and then a plan of work and a design team like we have in some of these other areas? Now that we've got this relationship and this platform, what about empowering women and communities? Who's thinking about that? Who works on that? Can we try and set up a dynamic where people can find each other? So this is how we're thinking and hoping that a center can facilitate a platform for a big body of work. Sure, we put our foot in the door as it started with, we need some healthcare providers, but we're expanding that to be much more inclusive and more holistic. But I'm going to stop screen sharing here so that we can have some conversation. And I would love to get some questions, some comments, some pushback. Let's see. Looks like we've got some folks that are, we're triggering some connections to people saying, I might want to talk with some of you and see how I can get connected, because, and that's what some of these conversations are about. Michigan is so big, so often we don't know what each other are doing. I'm sure there are people who are doing things in Rwanda that we don't know about, we should know about, but if we came together as a community of practice, we could play off each other and do great things. So, so thanks for those of you who are maybe putting in some of those connections, and they'll probably trigger some emails down the road. Maybe while we're seeing if there are any questions or suggestions, I wonder if I could pose a question for you, John and Kirstin. John, one of the things you had mentioned, you know, the fact that there's variable resources that you observed. How much of that was a viewpoint from Kigali? How much of it is, as soon as you got out of the capital, Kigali, to other parts of the country, what was the drop off? You know, I think of the drop off between Ann Arbor here In rural Michigan, yeah, there's a drop off. But in Africa, it's something else. So there's one thing to be building up the system and the towers of excellence in Kigali. What were you seeing or hearing about once you got outside of Kigali, and how variable were the resources once you got there?
That's a very that hits the nail on the head for sure. And as I mentioned, I had the opportunity to, when I went to interview all the surgeons around, I got to travel to the different there's 4 larger hospitals in Kigali, and then the provincial hospitals are sort of the next step up. And most of the district hospitals just have clinical officers. And what was, it still persisted. I think the baseline is just different. You're right that the kind of level of scarcity increase as you go to the periphery, as with any healthcare delivery system. But we were also there when like the drones were starting to deliver blood. That was a thing. And so, Rwanda is really small. It's just hilly. And so things are measured in time. They're not measured in distance. And so, we would find that, pockets of care might not necessarily make sense because they might be rural, but they existed. What didn't exist the further you went out in the periphery was the system to get them all together. And so when I think of trauma care, if you were in Kigali and you could get to SEMU, the ambulance system, then you could sort of, reasonably make your way through that system with, its variability. But as you're sort of alluding to, there are some hard stops that keep that from happening. But I'll tell you, as a visitor, I couldn't have guessed, because we'd go to one district and I would expect it to look like the last district that we saw. And that was foolish, because this was the one where they happened to have a blood bank because there was another partnership in the past. And so, that exists there. So I think one thing that came out of our last conversation with the deans in Rwanda was sort of the building of a system would require actually, understanding the system for trauma care, and more than relying on partnerships, communication, knowledge, like local knowledge, but rather having a real system exist.
Great, thank you. Christabel, I wonder if I could ask, do you think, and I think you spoke already a little bit about this, but Rwanda seems to be able to attract outside donor money, but then they seem to be investing themselves in their own health. How does that work? It seems like the haves are getting more. And are we right that we're seeing Rwanda maybe putting more of a higher priority in their own self-investment in health? Is that what we're seeing, or they're just better at brokering outside dollars?
Thanks. That's a great question. I think firstly, I did notice that it's interesting to see just how much in terms of resources they're able to pull externally. But there is actually physical room to increase their own spending. So currently the government of Rwanda spends less than their other counterparts in the same economic stratosphere on health. And so one of the aspects under the World Bank financing project that got approved in December is to increase the amount of local spending on healthcare to be comparable, if not more. Hence the move to employ more healthcare workers as part of the public sector. I think my own personal perspective on these issues is a little bit of the if you build it, they will come type model, where I think the government has a very strong and definite direction. And I think that certainty gives donors just the assurance that there's a direction and there's a focus in the use of the funds. And that's what I mentioned during my presentation about leadership, and just the importance of having that higher level interest in really building not just, increasing the numbers, but building a system that has the quality to back the numbers. And that's something that we see, and it's really attractive, and it does attract dollars externally, but there are definitely moves internally to increase government spending as well.
Please, Kirstin.
I was reflecting on, thank you for that incredible summary, Christabel, thank you. As I was reflecting on just how we calculate healthcare investments, though, it reminds me of just these stories of the lessons of how Rwanda functions in terms of at the ministry level. And I can't speak to the like what is happening in real time now, but there has been a structure called the social cluster in Rwanda, where the various ministries invest, including the Ministry of Health, but it could be the Ministry of Gender and Ministry of Education, will come together to think about the dollars that we have, like how does the dollar move the country forward the most? And so in some ways, I almost wonder if these kind of, if you had to like boil it down to where the numbers are in terms of like healthcare spending, if it was just coming from just the Ministry of Health, for instance, or however that dollar is, wherever it's, whatever bucket it's placed in, I think it would just be interesting to think about it from how the social cluster works in Rwanda and maybe peer nations, like what the comparable structure would be, just if it almost like underestimates those investments. It's just something I haven't actually really verbalized that before, but just as we were reflecting on kind of where the accounting goes, I think that context from Rwanda is, it's one of the most like powerful governmental structures that I just found so fascinating during my time there. And I think that commitment to work collectively of like, even if this may not look as great for like my ministry books, like I know this is the right direction for the country, was just such a genuine message I saw during my time there.
Yeah, and I know I've been really pleased that my partner John Ianian, in terms of this whole center initiative, that's what perked his ears up to really think about the policy initiatives and trying to, and why you've got the microphone, Kirstin. Some of my observations in other African countries is there's not that much conversation between the Ministry of Education and the Ministry of Health. So I was involved in shaping a big initiative called the Medical Education Partnership Initiative from NIH that started about 10 years ago. And one of the things that we insisted is that the Ministry of Education and the Ministry of Health had to be working together. The Ministry of Education is turning out these health professionals totally disconnected from what the Ministry of Health needs. And the Ministry of Health has all these needs, but they're not communicating with the Ministry of Education. So that's the typical dynamic in most African countries. What was your observation within Rwanda? How much crosstalk was there across the ministries? Because, obviously the finance ministry, feeds the ministries, but there's a lot of potential harmony, if not synergism, between the Ministry of Health and Ministry of Education, or Science and Technology. Was the Ministry of Health, did they really care about climate and the environment? Did they care about the education of women and children? What did you see in terms of the cross-ministerial, at least, interest?
Well, that's a fascinating question. And I don't want to risk repeating myself, but I think that the social structure or the social cluster mechanism was it was a true mechanism for trying to encourage that crosstalk. But I think beyond that, we've all talked about, geographically, just Rwanda is a small country, but also at the most micro level, I felt that everyone, or at least our observations, is that everyone's just so connected. The WhatsApp discussions between folks at the highest level in terms of just being in real time discussions about, oh, we're learning about this this initiative and we need support and let's have a meeting. And I felt that it was abundant communication, if you will. I can't speak directly on like the current context or necessarily cases or examples of meetings that I was in, but I guess one concrete example that's been written about from Rwanda, I think to be a case in point of this harmony or harmonization across ministries would be the vaccination efforts of HPV. This predated our move to Rwanda, but it has been something that's been written about, and it definitely, folks from the Ministry of Health are, more, I think, on the authorship side of sharing that story, but it definitely, it absolutely involved the Ministry of Education to ensure that young girls across the country could be vaccinated essentially within like 2 days of this of HPV. And so I think that's a case in point for where that harmonization has happened. And I think it's absolutely necessary for these initiatives that we, health is, all of these are social constructs, and that we have to sort of put bounds, like this is healthcare, this is education, but we all know that everything influences the other. And so to the degree that we can, move things together and improve communication, the better.
Very nice, thank you. We have a nice question here. Beyond health professional training and system redesign improvement, what do you think the level of interest is in co-produced research from those who sought you out, for example, around evaluation, quality measurement, health-seeking behavior policy? So are they just looking to get more workers into the field, or what is the level of interest in the academic places? It's an interesting question. Again, this has been a different dynamic for me. I'm used to places coming and they want to partner with us, but they don't have necessarily any money, but they want us to help go for a grant or something like that. So the Ministry of Health says, no, we've got money. We need talent and we need ideas. So this is, but we just don't do contract work. We need to do. So to answer the question, a lot of the conversations have been shaped by the Ministry of Health, but they're so closely intertwined with the universities, more so than I've seen in other countries. So a lot of times there's a real tension between what the ministries are doing and what the universities are doing. But I see the universities working very closely. So whenever I'm talking with university leadership, they just want to develop their faculty, their academic programs. Can you help us with research development? How can we have joint projects? So I would say that is very much an interest for the academicians. I don't know what you saw, John, in terms of were they looking for academic development, or were they just looking for advancing their skills?
Yeah, I think this is excellent question, because I think Rwanda is the right place for this sort of thinking. With HRH, there was a plan from the very beginning to evaluate it, monitor evaluation, and scholarly assessment of, is it working, what's not working. I was there, like I said, with a research hat on, not to be a surgeon, but rather to be a research trainee. And it was very clear from the RBC, Rwanda Biomedical Council, that I was expected in any research work that I was doing to have 1-to-1, and some were saying 2-to-1, Rwandan first author papers with anything we did, with the notion that they're only interested in research if it's developing research capacity, not research to measure health systems capacity building, but sort of the meta capacity building of saying, yeah, that's all good and well to measure and say that it worked, but make sure that you're bringing someone alongside you. I'll say there's a hunger and a value for that. Unfortunately, this is just anecdotal. I don't speak for anything beyond what I see with my own two eyes, but it seemed that the high achievers were the high achievers. And so they got a bunch of different titles and hats and roles and jobs, and not FTEs for it, and not, research analysts for it, and not extra time and money for it. And so it was hard. There was is with the School of Public Health at University of Rwanda, a research training program through some of our Harvard affiliates. And just a vignette from the last conversation we had with Dean Bekele, who's the dean at UGHE, we were talking about moving beyond like trauma skills development programs to sort of thinking about how to build trauma systems leaders for the future. And I loved it because Dean Bekele is like, yeah, we have a great health leadership curriculum. We could put him in that. And, if you wanted to have some fellows from Michigan come take part in those classes, we would love to have them here. And, maybe we could take some classes in Michigan too, but, we have a program for that, so there's a desire to build their own leadership. And just what I've seen, again, my opinion, what I've seen is they're attracted to high achievers, high performers. They're not looking for, at least the people I've been with have not been looking for somebody to come do it for them or do it for free. But they just say, who are the people that are really good at this? We want to work with them because we want to learn how to do it. And then they can leave because they're all going to leave at some point. We're going to be here, and they want to keep going.
Thank you.
Yeah, Joe, I'll just echo what John said for nursing and midwifery as well. I know that they are very interested in, quality improvement, which is a really, a very specific thing in a hospital, in healthcare that they could be working on, because we are talking about quality, and they're very interested in evaluation and quality measurements. So I would think the answer is yes to the question from the gentleman about things other than professional health training. Again, leadership as well. They were very interested in, how do I negotiate for more staff? How do I negotiate? Things that aren't necessarily taught when you're in nursing or midwifery or medical school, for that fact.
Maybe while you're speaking, Jody, you could pick up on this this point from Nancy Love. Nancy, as many of you know, professor of engineering and co-leads our climate vulnerability and health group. But she makes the point about train the trainers.
Mm-hmm.
How, and you've probably done more of this than any of us, Jody. How generalizable is that? Is there a generic curriculum? Nancy's focused on water, air, sanitation, health, that whole arena.
Mm-hmm.
And as we're trying to enable others, and that whole train the trainers curriculum, no matter what the content or what the topic is there a generic core that we could develop or focus on that that could be customized to a discipline? How generalizable, or what's been your experience with thinking about train the trainers?
Sure, I do think it is generalizable. So I think it's really important when you have a train the trainers methodology that if you're first level of trainer, the first people that you're training, they really are going to become the champions. And it's like what everyone has been talking about, working yourself out of a job, right? So you get over there and you do this remotely, or they come here to learn some new skill or to learn some new way to deal with a problem that they have. And you work through it so that they have time to learn, and then they also have time to be sort of supervised and work together with you as they learn to train other people, so that once you decide what it is that you want to establish, it's easy to do that when you have a core group of people then who take the ball and run with it after they've gone through this training with you. So I think it's very generalizable.
Oh, good. Well, I know we're getting close to the hour. We're going to be wrapping up at 6:30. One of the things John Ianian and I are fantasizing about is, we've I think made a lot of traction all during COVID in terms of getting some co-design projects that started with some pretty high aspirational, but suddenly we've gotten into a lane, I think, that's working really well for us around everything that has to do with trauma. And now with nursing leadership, we've got design teams that are coming together. And now we've got some examples that we could hopefully replicate, multiply into more of a diverse, holistic platform. John and I are starting to fantasize about an actual physical trip. Especially, I think particularly in low-income countries, but particularly Africa, most things are set up face-to-face. It's hard to do things. A lot of things happen face-to-face, and when you're present, and so we've done a lot just by Zoom and a lot of conversations, but we're hoping to start some physicality in terms of thinking about a trip and thinking about what are some of the other elements that we could bring into this, especially since we've gotten the attraction of the ministry, some important schools about taking a new way forward that's really a co-design model with the Rwandans. One of the things that I'm capturing maybe as a last point, that is also with a question that's difficult to answer. Rwanda is very much embedded in a complex regional situation with a difficult past and a complex present. How does this initiative connect to the regional dynamics? Yeah, I always think about Rwanda, the next presidential change, or, we had such a wonderful Ethiopian platform. One of our faculty members is the Minister of Health, Leah Tedesi. I just spoke with her last week. Things are crazy in Ethiopia right now. So many countries in Africa and East Africa, it's fragile and it's complex. And I'm not sure how to factor those things in, to be honest with you. We can't be naive. I think I personally want to continue to be aware and hope for the best, but be very mindful about the things that could happen around us. But yeah, I started off talking about Paul Kagame wants us there. Controversial figure. And there are plenty of people who would say, boy, if his fingerprints are on anything, I don't want to have anything to do with it. So I think we have to be mindful, but I think some of the people would say we also share some of those complexities in our environment and how we're saddling up with our politics. So I don't want to minimize that point, but I don't know what else to do but be mindful. Well, listen, I think it's been a great discussion. Again, I thank Christina, who's been behind the scenes recording this, and we are going to be putting things up on the web. We're trying to capture the comments and make sense out of this, capture people's advice. Again, this is about making connections and creating a community of practice. So if we can create momentum around better systems for health, for those of you who are interested in health system strengthening, and yes, for people who want to do things in Rwanda or who are energized about a new idea or tag along to this space, please let us know. But thanks, panelists, for a very energizing discussion. And I'll close and wish everyone a good evening. So thank you.